Okay, in this video we will talk about the psychiatric interview and mental status examination, inshallah. So this material would be beneficial for psychiatric residents, medical students, and such. And of course, I'm doing this for myself firstly because I'm going through some exams. So this will be beneficial, especially for those who are planning to do some board exams. I'm talking about clinical exams, of course. And I'm doing this for myself, as I said, but the other purpose here is to check for these to this new setting. I'm talking about this live YouTube live by the laptop um, uh, and by this app. I'm new to this, which is the OBS software. So let's just go through it. It's just a review, okay? The psychiatric interview and mental status examination. First of all, let's just talk about what is the purpose of psychiatric interview and mental status examination, and is there any general purpose or goal for the psychiatric interview, and if there's any specifications that are there for many situations or specific situations. So let's start with this. Yes, of course, there are many details that can vary, but the underlying goal of all interviews in psychiatry is to provide a safe and respectful opportunity for the patient to tell his or her story. That's it. So, safe opportunity to let the patient tell his or her story. That's it. So, safety first, then to understand the patient. And regardless of the situation and the setting, regardless of whether the interview takes a minute or an hour, each interview has a similar underlying structure that involves observation, interaction, assessment, and the plan. That's it. Again, observation, interaction, assessment, and the plan. And all of these things are actually going in parallel with each other. But you need to observe, interact while observing to gain more information, and so on. And then the assessment would be there as a result of that observation and interaction. Then to reach a plan according to that assessment, of course. Okay, why we are talking about this? Because it's important and it is essential for anything to do, for everything that you do in this life, to know the goal and the purpose behind that. So that's it. Another important thing in psychiatric interview is to know at least the initial goal of the patient, or at least the referring clinician, because sometimes you know that the patient is getting there by himself or herself, and sometimes he's not there by himself. He's referred by another clinician, or there's some kind of consultation or something. So you should know the initial goal or our goals of that visit or that consultation. Okay, let's just go for more details. What's the general attitude that the clinician, I'm talking about the psychiatrist here, what is the main and the general attitude that the psychiatrist should or must adopt? It should be something like, it is an attitude of respectful curiosity. That's it. Respectful curiosity. Respectful, to respect the patient, to make to respect his or her dignity, to respect his or her even autonomy somehow. But on the other hand, you need that kind of curiosity. You should have some kind of, you want to know. You are actually listening. You are an active listener to what the patient is saying. So yes, you are respectful, but not in that passive way. We are talking about active listening. That's why we call it respectful curiosity, respectful curiosity. Okay, because sometimes respect may push you to just to withdraw somehow, or not to push yourself or something. Okay. Another important thing to talk about in this, I would say, introduction, is that interviewers in general, clinicians, okay, let's just, and that's true for most interviewers and clinicians, and that's true for you, for me, for everyone, and you should assume that until proven otherwise. And actually, even if it was proven otherwise, you should just keep assume that and tell yourself that. What is that? That is, most interviewers learn to listen in ways that conform to the needs of the patient and situation. But we have another thing. They also tend to listen in ways that, in the way that they know, actually. So they are listening according to their own training and their own theoretical and personal biases. So that is a fact. It's not a personal thing. So that's a fact, and you should assume that, and it's okay to accept that somehow, but you should be aware of that. Again, each clinician, of course, he's listening to the patient in a way to confirm the needs of the patient, of course, and the situation according to the patient and the goals and the chief complaint of the patient and the history of that patient, and of course to the situation according to the, for example, we are in the ER or in the outpatient clinic or the inpatient sitting, or in psychotherapy. We will talk about these settings in separate. Yes, of course, that's somehow an objective thing that clinicians do. But another thing, that the point here is that interviewers tend to listen in ways that confirm their own training and their theoretical and personal biases. What does that mean? That means, for example, if we are talking about psychiatrists in general, they tend to hear this in with an ear for symptom clusters. That's it. As psychiatrists, we usually listen to the patients looking for cluster of symptoms. That's it. Because we are looking for diagnoses to diagnose the patient. If there's any, DSM-5 diagnosis or ICD-10, ICD diagnosis or something. So, but for example, if we are talking about cognitive behavioral therapist, he or she would listen to the patient with an ear of cognitive behavioral therapist. That's it. So he or she will look for the emotions, cognitions, and behaviors, and the core beliefs and the intermediate beliefs and the coping strategies and so on. If you are a psychoanalyst or a psychodynamic psychotherapist, you will look for something like the unconscious conflicts and these things. So it's okay to admit that is the situation, but you should know, on the other hand, that the more broader approach that you adopt, the more accurate you get the patient and you understand the situation. That's why, in general, in psychiatry, we are talking about the biopsychosocial approach, and here we are going through the details. Okay, I'm very sweaty. Again. So, in medicine, we are talking about the biopsychosocial approach. Biology, psychology, social sociology. That's it. And when we evaluate patients, we should study the areas, all of these areas: the biological aspects, the psychological aspects, and the sociological aspects. One of the major errors is that clinicians who study only the areas that interest them, they risk making systematic errors throughout their careers because they study just one part of that. For example, some clinicians would prefer to, or they are professional at some kind of biological aspects, neurological aspects, to neurotransmitters, neural circuits, and such. So they are neglecting somehow the sociological factors and the psychological factors. On the other hand, we can find some clinicians with psychological interest. They would prefer to deal with cognitions, emotions, and behaviors. They are not aware of the biological aspects or even the psychological aspects, and that would be some kind of reductionistic, I would say, approach. So we need the biological factors. Biological factors, what we mean by biological factors is start with the genetic factors, hormonal factors, neurotransmitters, general health, I'm talking about, for example, medical comorbidities, drugs, medications, sport, diet, everything that is related to the biology. Psychological aspects, we have more than one model about the psychological aspect. I'm not gonna talk about the details here, but we have the descriptive model, and we have the narrative model, I would say. The descriptive model is about the description of the symptoms, and that and the I would say the perfect example here is DSM-5 and ICD-10 and 11. These are some examples of the descriptive model of the psychological aspect of the psychiatric interview. So we are looking for the signs and symptoms that are described in a way, and they are gathered in some cluster of symptoms, and that would manifest some kind of descriptive clinical syndrome like depression, anxiety, or such. But with this approach, there's something called confirmation bias. Confirmation bias has a lot of okay, let's say it in this way. We generally, as psychiatrists, I'm talking about us, we might have a tendency to repeatedly see the same diagnosis again and again, the same findings. So by this repetition, we tend to confirm the diagnosis of other patients that had the same complaints, because we tend to, okay, we are used to do that. That's it. Okay, this is it. Another thing is we as clinicians also tend to diagnose patients with clinical syndromes that we can treat. That's why you can find psychiatrists actually diagnose patients with depression, anxiety, and these syndromes with somehow known treatments. They prefer to diagnose patients with these diagnoses rather than diagnose them with personality issues or such, because we deal actually with other diagnoses than personality disorders, and we are not good. I'm talking about psychiatrists in general with personality disorders. So okay. Another common bias with the descriptive approach of psychology, again, I'm talking about the descriptive approach, when you are looking for cluster of symptoms to diagnose a patient with some diagnosis. So you tend to diagnose the patient with the diagnosis that you are usually dealing with. So as a psychiatrist, you tend to diagnose a patient with depression, anxiety, OCD, schizophrenia, bipolar, and so on. You are not usually diagnosing patients according to their family situation or their economic status or such. While a cognitive behavioral therapist would diagnose a patient more roughly according to their core beliefs, according to the cognitive errors and such, without that emphasis on the name of that clinical situation, like a major depressive disorder, generalized anxiety disorder. No, they actually don't need that to do the treatment, despite they do actually most of the time, but I'm talking generally. So another thing is the loudness of that syndrome. So if you have a patient with prominent depressive symptoms, that would somehow obscure the symptoms of the underlying avoidance personality disorder, and that would be the actual cause, I would say, the major cause for that depression. But because the loudness and the brightness of that diagnosis, which is depression, that would obscure the other diagnoses, like even OCD. Okay, and sometimes patients themselves, they tend to be evasive actually about other symptoms like OCD, PTSD, about some kinds of anxiety, especially those anxieties with more prominent avoidant symptoms, and the patient would direct you toward the more loud and obvious diagnosis. So you should check that. Okay, that's about the descriptive approach. Is there any other approach? Yes, we have another approach which is called the narrative approach, and that would be related to the theoretical framework that you are adopting. That's it. If you are, for example, a cognitive behavioral therapist or a psychoanalyst or a psychodynamic psychotherapist or a dialectical behavioral therapist or such, so you would understand the symptoms of that patient and to put those signs and symptoms within your theoretical background about psychology. So, for example, cognitive behavioral therapists would put those signs and symptoms within the cognitive conceptualization diagram or within the cognitive model. A more biological psychiatrist, I would say, would put these signs and symptoms in a way of understanding the neurological problems, neurotransmitter things, and the activity of the brain in some areas and such. So that is the narrative approach. We are still talking about the biopsychosocial approach. We've talked about the biological aspect, and now we are talking about the psychological aspect we have. Within the psychological aspect, we have the descriptive approach and the narrative approach. We've talked about that in general. Let's just talk about the social approach, the social aspect of the biopsychosocial approach. The social aspect is not just sociological. It's a general term here, social, but it refers to the sociological. It's not psychological, okay? Biological, psychological. So social means social refers to the sociological aspect, the sociological issues, religious issues, spiritual issues, ethnic issues, and racial issues, and so on. That's it. So other issues around you, environmental issues, I would say. So that's it. And all of these things can have an influence on the psyche of the human being. Okay, let's just talk about the performance of the interview. In the American Psychiatric Association publishing textbook of psychiatry, they tend to divide the interview into two phases, roughly, the initial phase and the later phase. And after that, we have the negotiation and summary. The initial phase is the phase uh, where we ask about the patient's chief complaint or the patient's chief concern. So that's the initial phase. Then the later phase where we actively develop the story. We understand the story in more details, and also we do the mental status examination at that phase, the later phase. After that, we reach the assessment and and uh, and the plan, and we do both of these things with some negotiation with the patient. It's not just a stamp or something. Uh, it is reciprocal, I would say, activity. Um, so let's get back to the initial phase. The initial phase, again, the initial phase would be the patient's chief complaint. First of all, you know the patient, the ID of the patient, the name of the patient, the age, gender, the marital status, and such. Then you go to that initial phase, which is the patient's chief complaint or the patient's chief concern. We have two main goals here. Two main goals in this initial phase. First is to understand and explore the patient's current chief concern. Actually, we are sincere about understanding the patient. So we are looking for the chief concern. And that's important. A lot of patients actually, and a lot of people consulting me about different things in their life, they tend to present with vague symptoms, just like I want a consultation or something. I have my life is ruined up or something. So I need a chief complaint. I need something to start with. So that's a big issue actually. In psychiatry, it is much easier than in, I would say, in psychotherapy or in family therapy or such things. It would start with such obvious symptom like bad mood, sadness, fear, uh, such things. But in consultations and general consultations and therapeutic consultations, that would be much difficult. But you need to achieve that, and that is the first goal of this initial phase, is to understand to know the major chief concern. Okay, and the current chief concern of the patient. The second goal of this initial phase is to give yourself the time and the information to begin to make a set of tentative hypotheses about the patient. We call them differential diagnoses somehow. So the first thing is to understand the patient sincerely, and the second thing is to give yourself that moment when you think about what the patient is saying, and you decide where to go, what to ask next, and what to do next. So, okay, and you should remember that the initial phase, it is for the patient, and it's not sometimes, it should be like this. We should write the chief concern and the chief complaint as a quotation from the patient's own words. So if the patient says something, even if it is something, I would say, not it make no sense in some way, you just write it as it is. So the initial phase, you should know that initial phase is for the patient's point of view. Initial phase is for the patient's point of view. That's it. How the patient is seeing things. Okay. We will talk about the write-up of the write-up of the psychiatric interview. We are not talking about the write-up, how to write the note or the psychiatric history. We're talking about that phase, when you just ask the patient an open-ended question, but start with, what is your main chief complaint, or what brings you here? Why are you here? How can we these things, okay? After that, we start with more open-ended questions like, explain more to me. What about that? And of course, you need to know the timing of that chief complaint. Where did this thing started? When did this thing started, and so on. So then with more open-ended question like, tell me more about that. What happens next, and so on. And then the later phase actually is start to develop. And you should know that these are not separate phases actually. They are integrated somehow. So the later phase, which is the deepening of the understanding. The first is the chief complaint, and then the deepening of the understanding. And we have three major tasks in this later phase of the psychiatric interview. The first task is further development of the history of the present illness. So the patient came with the patient is here with some chief complaint, and we need the history of that chief complaint, the story of that chief complaint, the story of the concern, that main concern. We call it the history of present illness. The history of present illness. So we need further development of the history of present illness. That's it. That is task one. Task two is the collection of other aspects of the patient's story. Yes, we need the story of this present illness, but if we have pertinent positives and negatives around the history, it's not just direct to the point, but you need to know all these things. The third thing is to perform the mental status examination. We will talk about that. So, complete the history of present illness, know other things, other aspects of the patient's history, and the mental status examination. So, what's the difference? What's different here is that in this phase, I'm talking about the history of presenting illness, we convert things. Okay. So, we shift the patient concerns and complaints into an understandable story. Okay, again, we have the patient's concern and complaints. That's the patient's point of view. We shift that point of view to my point of view. It's not about my opinion, it's about what I understand from the patient. It's not about my opinion or my judgment. No, it's about my understanding of the story. That's it. My understanding of the story. That would be good. So, I write down, we will talk about the write-up next, but now we are talking about how to understand the story of the patient. That's it. Okay? That's the history of present illness. Okay. At the end of the initial phase, we've just talked about the starting of the open-ended questions. When you get involved with the later phase, you tend to shift from that open-ended approach, I would say, open-ended questions, open-ended sounds, open-ended gestures, and so on, to more closed-ended questions, specific questions, okay, one by one, to achieve some facts. It's not about the patient's concern anymore. It's about facts. You need to understand the story to know what's going on. That's it. Okay. So, and prior to the end of this phase, the interviewer may want to ask the patient if there's anything he or she would like to add to that story. And of course, there are a lot of techniques actually, like summarization and reflection to make sure that you are understanding the story right. And after that we reach the negotiation and summary phase. That's it. So in this negotiation phase, here's the time for psychoeducation, referral to another clinician or clinic if needed, gaining a sense of whether the patient has been satisfied with the assessment process or not, if there's anything missed. Okay, that's it. This is I know this is general, but okay, let's just continue. Here we have some techniques. Now we'll talk about core interviewing techniques. We call them core interviewing techniques. Techniques that we use in psychiatric interview. We have some techniques called non-specific techniques, and other techniques called non-directive techniques, and we have some techniques called directive techniques. So, what about non-specific techniques? Non-specific techniques, these are the general techniques, I would say. It has nothing to do with okay. How can we define general techniques? They are general techniques, okay, non-specific techniques. They somehow make the background or the groundwork or the baseline for the whole interview. Let's talk about some examples to know what are these non-specific techniques. I would say the examples would clarify the definition of non-specific techniques. One of the most important thing is attentive listening. Attentive listening. So, attentive listening, that is that involves some tactful eye contact, encouraging body language. You are just telling the patient that you are listening, and you are an active listener. You're not just a passive listener. That's it, an active listening. Okay. Another non-specific technique is confidentiality. And that's important in every aspect of psychiatry, especially in medicine, especially in psychiatry. Another non-specific technique is called neutrality. And here we are talking about, I have a lot to talk about this technique, but generally we are talking about just to be in, I would say, equidistant from issues, and try to not judge the patient before you get the right understanding. So that's neutrality. Another thing which is another technique which is the therapeutic alliance, and that's very important to, for any treatment to proceed. So the therapeutic alliance. That's it. Then we have the therapeutic effect. Okay, what is that? Okay, and that would be developed when after the patient feels that he or she is heard, actually. Okay. Another thing is called an uninterrupted positive transference. I'm not sure I'm gonna translate that. So let's just go to the non-directive techniques. What about non-directive techniques? Non-directive techniques. These techniques are the techniques that are used to encourage the patient to continue on the train of thought. That's it. These are the non-directive techniques. Techniques that are used to encourage the patient to talk and to continue with their history and to talk and to give more details. So that are the non-directive techniques. Here we have some examples about the non-directive techniques. We have what's called open-ended questions. And you know, open-ended questions like, tell me about this, tell me about that, what brought you to the hospital today, how can I help you, these kind of things, okay? Open-ended questions. What is your complaint? That's it. We have something called open-ended sounds, like You encourage the patient to continue and to talk more while he's talking. That's it. While he or she, of course. Open-ended sounds. We have something called open-ended encouragement. It's not just sounds like It's with some sound like, okay, go on, tell me more about that. Would you explain that to me, please? These kind of things. Okay, these are the open-ended encouragements. Another non-directive technique is called reflecting content and feelings. And there's another thing that is similar to that, which is repetition and restatement. So when you hear the patient is talking about something and the patient is, the patient have finished his statement or her statement, and you just repeat that to the patient, to tell the patient that you are listening, you understand the patient, and you are actually asking the patient about your understanding, if it is a true one or not, if there's any wrong with that narrative. So these are the open-ended techniques. What the non-directive techniques? We have other techniques called directive techniques. So these techniques actually, from their name, have narrow focus approach, and we use them to elicit factual answers and objective things. You know, we need answers. One of these techniques is called closed-ended questions. These questions are usually answered with short answers, yes or no answers, or factual answers. What is your name? Did you have any drug history? Is there anything? When you ask a question, that question is just can be answered with one or two words. It's just an closed-ended question. That's the name for it. Okay, another thing is confrontation. Confrontation, it's something like, it's not a synonym for an attack. It's just when there's any discrepancy or any, yes, I would say discrepancy in the history of the patient, and you just confront the patient with that fact. You said that, but you said this. You said this and that. How is that? So this is confrontation. Another thing is limit setting. Is limit setting and transitions, and that makes you somehow the I would say the leader of the conversation as a clinician. You just if you need, for example, the patient is talking too much about something and you need to proceed with the history taking, you just tell the patient that I'm sorry, I would hear more about this and that. Let's just go to this part. Let's just talk about this. We'll get back to that object. Let's just move to that matter and such. And even for the timing thing, you just tell the patient, we are short of time. I need you to tell me more about this and that, and so on. Okay. So these are some techniques that we use in psychiatric interview. Again, we have non-specific techniques. These non-specific techniques we use them all over the psychiatric interview, like active listening, confidentiality, neutrality, therapeutic alliance, and such. We have non-directive techniques like open-ended questions, open-ended sounds, open-ended encouragements, and reflecting contents and feelings. We use these techniques mostly at the beginning of the psychiatric interview, and with the process and the development of the of the interview, we move to more directive techniques like closed-ended questions, confrontation somehow, and we limit setting, and we make transitions according to the clinical according to our clinical judgment and according to the situation. Okay, there are some comments and questions that tend to reduce clinical effectiveness. We call them drailing errors. Drailing errors. So these drailing errors, as I said, they have a negative effect on the clinical effectiveness. That's why we need to know them to avoid them. Just to make a note here, some of these drailing errors can be used, I would say judiciously, if you are a professional clinician and you know what you are doing. You may use them in a selective case, in some selective cases. But in general, you need to avoid these trailing errors. What are these trailing errors? The first one is double questions. Double questions. When you ask the patient more than one question in one sentence. So, for example, you ask the patient, did you have any, do you feel sad or anxious, and are you using any kind of drugs? When you ask these two questions at the same sentence, and you are not waiting for the answer from the patient, that seems like you are not listening. You don't care about the answer actually, because you ask the first question, you ask the first question, then you don't wait for anything to listen for, and you don't wait for the answer. That means you are not interested in the answer. So that's why you need to ask each question, and to give that question its time, and to wait for the answer, and so on. So double questions are one type of these trailing errors. Another trailing error is false reassurance. What does that mean? It means that you should not reassure a patient about something you are not sure about. It is false reassurance. You are lying. And that would break the therapeutic alliance, and that would affect that relationship between you and the patient or the family of the patient. You should not make any statement if you are not sure about that. So if you tell the patient everything would be okay, you would be free of symptoms within 1 week or such, you are not sure about that, why you tell that? So that's different from reassuring in general. It's okay to reassure patients in general. To talk about, for example, if you have a patient with major depressive disorder, and you tell the patient that you have major depressive disorder, and this is a well-known, it is a common diagnosis, I would say, and a lot of patients are treated actually in our hospital and so on. You are giving I would say a sincere answers, truthful statements, and that's okay. But you should not give any false reassurance, just to make the patient and yourself feel good about that. So another problem and another error is the judgmental questions. When you ask the patient about something and you need to know about that thing, you should consider to ask the patient sincerely. And as we said before, with respectful curiosity. What does that mean? That means I want to ask the patient about, for example, drug abuse. I would ask him like this: do you use any illicit drugs? Actually, I would start with medical, with legal drugs. I would say, do you use any medications? Do Do you have any of these things? The patient would answer, for example, no. And then I would ask, do you use anything other than prescribed drugs by your own? Any illicit drugs do you use? You just ask these questions without any judgmental, I would say, even your body language, or I would say your sound, while you are asking the questions. So it's not like, do you use drugs? When you say that, you are just telling the patient this is something wrong, and you just need to say no, and the patient would not answer your question sincerely, and that would not benefit you or him. You need the answer, so just ask the patient in a normal way, I would say, without any judgmental. I'm not against judging people actually in general, but it's not beneficial here actually. So you ask the patient, do you know that drugs are haram in Islam, and it destroys your kidneys and your liver? And okay, now you are evaluating the patient. It's not the right time for this. So that's the point here. So this is about the judgmental questions. So you need to avoid judgmental questions as long as you can, to elicit more information. And of course, especially in the initial interview, I would say, this kind of error may push the patient away, and to actually to break that patient-doctor relationship between you. So why to do it? Okay, another thing. We have another error called non-verbal disapproval, which is something related to what we've talked about now, judgmental questions. These are non-verbal disapproval. So if you ask a patient about something like, for example, about illicit drugs, and when the patient is talking about illicit drugs, you have this, for example, disapproving face, I would say, or something like, you are not encouraging the patient to tell the truth. You are not encouraging the patient to to be with you. So again, I'm not against judging people about their and especially I'm talking about judging behaviors. This behavior is wrong, this is right, and this is wrong. It's okay for me. But now I'm evaluating the patient. The patient needs help, and he is there between your hands, and he's okay. He wants to be helped. So why to push him down and to push him away? So that would not help actually. So that's why we avoid non-verbal disapproval. That's one cause. Another drailing error is called poor eye contact. Poor eye contact. Okay, what poor eye contact? What's that? Poor eye contact because in general, when you are talking to someone, you have some respectful eye contact with them. But and I encourage actually in our part of the world, and actually in general, we should consider that poor eye contact is especially between two different genders, is a sign of respect. So you should not just do this. So some kind of eye contact in our communities would be a sign of disrespect, actually. So you just need to evaluate the pros and cons, and according to the situation, according to the culture of according to the culture, and according to the gender difference, and so on. Another drailing error in psychiatry, in psychiatric interview, is premature advice. What is that? Premature advice means that it actually these premature advices are the advices that you suggest prior to develop a solid understanding of the situation. So from the first 5 minutes or even 20 minutes of the evaluation, you start to give the patient some advices about their life. Even if you are a professional and you have this I would say perfect sense of clinical sense, and you can, and you are smart enough to diagnose the patient within these 20 minutes. But the patient is not understanding that, and the patient would think that clinician or that doctor is not actually does not understand me actually yet. So why he's doing this? Why he's giving me these advices despite his misunderstanding, his ignorance? So that would be something inappropriate. So that's it about this premature advice. So you don't give any advice before you understand the situation. The same thing for the premature closure. And so that involves accepting a diagnosis before it is fully verified. It's okay to delay the diagnosis. So you are out of time, and the interview is over, but you didn't reach the diagnosis. There's no hurry to diagnose a patient. It's okay to delay that for another time, another interview, to complete the evaluation before you start any medication or before you give a judgment about the diagnosis. So it's okay. So avoid premature advices, avoid premature closures. And you need to avoid actually another thing, another important thing, which is psychiatric jargon. So that would be confusing to the patient. So don't use it. That would not help. Okay. Again, although all interviews include a safety assessment and differential diagnosis, and as we said before, the main goals of each psychiatric interview would to provide a safety situation or a safety environment for the patient to tell his or her story. That would be the basic goal for any psychiatric interview. But with variation of the situations, and according to the type of the situation where the interview is done, different goals would emerge. For example, if you are in the emergency department and there is a patient in the ER, and you are consulted as a psychiatrist to evaluate the patient, or even if you are an ER doctor. So, what is the main goal and the primary goal in the emergency department? Is that the same for a patient in the psychiatric outpatient clinic? Is it the same for a patient in the in inpatient setting? No, there are, of course, there are some differences, major differences actually. Again, there are general goals, primary goals for each psychiatric interview, which are, as we said before, to provide a safety environment or a safety setting to let the patient tell his or her story. That's the main goal of the interview. But we have other goals and other primary goals actually. And that would be according to the situation. For example, if we have a patient in the emergency department, the main primary goal would be to make triage. What does that mean? That means to answer this question, is the patient is safe to go home to be treated outpatient or to be admitted as an inpatient for psychiatric evaluation or for psychiatric treatment or even for medical treatment. And the primary concern here is suicide and injury. So we are talking about safety first. Assume that we admit the patient after that triage in the ER. So the assessment within the inpatient setting would be more toward a proper diagnosis, more detailed diagnosis, and more fine and more, I would say, appropriate treatment. So the primary goal within the inpatient setting would be more precise diagnosis and more appropriate treatment. And the primary concern would be suboptimal treatment. We need the optimal treatment that we can do. Do we ignore any kind of safety measures in the inpatient settings? No, of course. We in every setting we do everything actually as we can. But I'm talking about the primary goal here. So in inpatient setting, the primary goal would be diagnosis and treatment, and the primary concern would be suboptimal treatment. If we are dealing with psychotherapy office, the primary goal would be to choose the right treatment, the right therapy, and the primary concern would be suboptimal therapy. If we are talking about evaluation in an oral exam or such, the primary goal would be to pass the exam, and the primary concern would be to fail the exam. So that's it. Another factor that make difference in the way you and the approach that you may adopt within the psychiatric interview is the types of the patient, So we've talked about the general purpose, and the general goal of the psychiatric interview is to provide a safe environment to tell the patient and to let the patient to tell his or her story. Okay, but we've also talked about the difference between each situation in ER that's different from the outpatient setting or outpatient clinic or the inpatient setting and so on. Another thing that makes some difference, a lot of difference actually, is the type of the patient. For example, if we have a revved up patient, we call these patients revved up patients, excited, agitated patients, psychomotor agitated patients. These patients with psychosis, mania, hyperactive delirium, substance withdrawal, or intoxication that will lead to agitation and so on. So the first thing here is safety, and the safety of yourself, other staff, and the patient. You need to talk with the patient with clear, soft-spoken, pleasantly firm language, and you may just ask closed-ended questions to the point, and first is first, and the primary to the most dangerous, I would say, to ensure safety, of course, and then to the most dangerous and the most probable diagnosis, I would say. So to ask the patient about drugs, to ask the patient about the signs and symptoms of mania and psychosis, because you may not be able to continue that assessment. But for example, for down patients with depression, patients who are talking they are barely talking or something, these patients may be depressed patients, or sometimes may be paranoid patients. And according to your differential diagnosis and your more probable diagnosis, you would actually deal with those patients. So if you have a depressed patients, that would be very different from paranoid patients. For example, if you have a depressed patient, a depressed patient, which is down patient, he is not talking too much, he's withdrawn, he's just responding with one word for each question. You would encourage the patient to talk more. You would be close to the patient, to warm up somehow with the patient, to talk softly with him, to tell the patient that you understand the suffering of depression and such. But for paranoid patient, you would consider that you should be clear. You don't make any vague statement. You just respect the boundaries that the patient is putting there. So and such. Another type of patients, we may call them odd patients. And okay, I would just skip that. But the approach for them is just about the differential diagnosis. If you suspect, for example, schizotypal personality disorder, that would be different from a patient with some specific cult. Okay. Another type of patients is called evasive patients. Evasive patients, and again, it's according to the differential diagnosis that you are thinking about. So, evasive patients may be obsessional patients. I'm talking about especially about patients with obsessive compulsive personality disorder, because these patients tend to talk about details, non-relevant details, and so when you are talking about with obsessive patient, you need to follow the affect, because these patients tend to ignore any emotionality and to look for the details, unimportant details, just details of everything. These obsessional patients. While on the other hand, and at the opposite end actually, we have histrionic patients. Histrionic patients tend to talk about everything in general, in some kind of vagueness, and they charge each aspect of the story with a lot of affect, a lot of emotions. So you need not to follow these emotions. You just need to follow the content and to direct the patient and to ask the patient about facts, about details. You can see the difference and the contrast between those patients and those patients. Obsessional patients, they are usually focusing on details, ignoring emotionality and affect. On the other hand, we have histrionic patients talking about emotionality. They actually usually do not provide any meaningful details, so you should follow the content. But both of them are usually evasive with their story. They are just you are asking about something. They answer something else, and they go there and so on. Okay, some patients would be evasive because they hide something, like drug abuse thing, because they are manipulating you. They want something. They want, for example, as sick leave. They want some legal report or something, like patients, malingering patients, or even factitious patients. Some patients would manipulate you because of their innate, I would say, urge to do that, like patients with personality disorders. But you should not assume that for all patients, because some patients would be evasive because they are not actually remembering those, for example, facts that you are asking about, like patients with dissociation. Dissociative patients, even patients with PTSD, may have some dissociative amnesia. So you're asking the patient about something and the patient is not remembering that thing, so he's just avoiding that thing, especially for patients with PTSD. Okay, what else? So we've talked about the types of patients, we've talked about the types of situations, and I think we may talk about local cultures. Of course, you need to take that into your account and to put that in your head to differentiate between different cultures and their understanding of different symptoms according to their culture. So, and in DSM-5 we have something called cultural formulation interview that would benefit you a lot. You should go to see that. Okay. Let's go directly to the structure of the write-up of the psychiatric interview. Actually, I would just stop this video and start it again to talk about structure of the write-up of the psychiatric interview. Okay, let's make it a different video, separate video.